All right, good morning, everyone. And you chose the right breakout, so thank you for being here. AMGA represents medical groups and health systems across the country, and they are navigating integration and alignment of their physician organizations. And specialty care has emerged as an important area where value-based theory really meets operational reality. We have an exceptional panel here for you today. They promised to be engaging and entertaining, so I've set the bar high for them. And I'm gonna be pushing them for very specific numbers and real world examples so that you could have takeaways. We're gonna go till about 5 minutes to 11, and then we're gonna have a chance for audience Q&A. So start thinking of your really hard questions to stump the panel. We have Angelo at the end, from Penn Medicine, where he manages over 500,000 risk-based lives. Next to him is Luke Harris, who manages 250,000 pediatric lives as part of Children's Mercy Kansas City. And I understand that's 50% of the kids in Kansas City metro area. And then finally, we have Wade Rakes, who's CEO of CareQuest Institute, who works on oral health integration. So we're gonna get started with Mark. You get the first one, and we're gonna start with the money question, because I know that's what we're all interested in. So again, you manage 500,000 value-based, risk-based lives at Penn Medicine with multiple payers, multiple geographies. So let me ask you very specifically, what would happen to shared savings, quality bonuses, maybe even contract renewals if specialty care coordination breaks down? Give us a specific example. What did poor specialty care really cost you prior to integrating into specialty care?
Sure. So thanks for the question, and it's a pleasure to be on the panel with you. So I wanted to pull some real world numbers because I kind of might have known that this question was coming at me. So I wanted to pull some real world numbers to give you some information. So if we think about specialty care kind of breaking down, as you're mentioning, which we know would never happen in any of our instances, I have a few possibilities of what could happen. So number one, and I think everyone knows this one, this is the easiest one, you're going to lose your RAF score, right? So you're going to fail to have proper risk capture. And that's going to happen a lot in your cardiology practices. It's going to happen a lot in your oncology practices, especially because some of those diagnoses tend to be complex. And what I hear from my PCPs, I feel like that's outside my purview, right? Does anybody ever hear their PCPs say that? So they feel like the specialists should be noting that, yet the specialists aren't always billing to the highest level of specificity. So missing RAF scores for us in 2024 led to a sub-1 risk score, and that ended up costing us between $2 and $4 million. So that was the easy one. Poor specialty follow-up also is another big problem that we have experienced. I don't know if you've experienced it as well, but we have a bandwidth issue. And we have a hard time getting people into our specialists. Tends to be a waiting line. So when people don't get to their specialists, we see things like failure to get people to guideline-directed medical therapy. We see people having failure for follow-up of their chronic conditions and ending up in the ED for what could be potentially avoidable ED visits. And that has cost us about $5 million in our Blue Cross contract in shared savings, and that was in the last fully adjudicated year, which was 2024. And then otherwise, you get fragmented care, right? So if people aren't seeing their specialists in the way that they're supposed to see their specialists for chronic disease management, you get fragmented care. When we get fragmented care, we see a lot of duplication. We see people get scans that they didn't need, that they already had previously. We see people having a second workup done because they didn't have the information about the first workup. And that has cost us probably north of $5 million. And that also was just in our Blue Cross contract. So this is a massive amount of money. Those are just 3 areas, but I could tell you that there are a lot of other opportunities that we have for specialty.
So I was adding that up. It's over $10 million, and that's each year.
Yeah,
and that's not even counting the waste in the system that would be generated.
Yeah, absolutely.
Luke, Children's Mercy Integrated Care Solutions, I hope I got that right. Your value-based program, $250,000 pediatric lives, 50% of the kids in the metro Kansas City area. How do you meaningfully and effectively engage pediatric specialists in value-based care? And there are challenges. There's really limited volume of chronic care conditions in the pediatric population. There's limited pediatric bundle care models, limited HEDIS measures in pediatrics. How do you, given the financial realities, how are you doing to actually engage specialists in value-based care?
Yeah, thanks. Appreciate the opportunity to share. So, one thing I would start off with is I think we all agree, that engagement of specialists is critical to actually achieve transformational care, right? And so, for us, I'll just, in terms of that engagement, it's gone through several years of failures, to be honest. Failures of, we are in a fortunate position that most of the specialists in our market, 80-90%, are part of Children's Mercy. We tried to partner with them and we tried to create alignment. We started by sharing data, thinking that data would drive action and appropriate behavior. That didn't work. The next thing that we did is we shared technology, gave them access to more information using some of the innovative tools. The technology wasn't the answer. And the third iteration, and what we're really excited about, is we're designing now an embedded, what we call a chronic condition value-based program. That's essentially a program that's designed within the existing agreements that we have, where we're functioning almost as if we're the payer, developing a pay-for-performance agreement specifically with our specialists, and creating a program that's aligned with the metrics that matter to them, that they're evaluated in terms of their faculty practice plan, and that are also important measures that are being evaluated at the enterprise level, but then also incorporate key metrics that make them now accountable for a population where they've never seen that data and information before. And we're giving that ownership to them so that they can innovate within their care model, really transform it, focusing on remote patient monitoring, focus on the kids that are not seeking care from that specialty division in a way that will meaningfully kind of drive action in behavior.
Well, first of all, I want to thank you. Often panelists talk about what worked. You talked about what didn't work, and often those are the most important lessons to share, so thank you for doing that. Wade, oral health. Oral health is often a missing piece of specialty care integration. Gosh, there's separate clinicians, separate benefits, but a huge impact on patients, cardiovascular, maternal health, diabetes, et cetera. How do you integrate specialty care? How does it look when it really isn't even integrated into the system? And how do you connect medical and dental?
Well, it's a lot. I could be here all afternoon. But one, I appreciate being here and raising the issue of oral health. Most folks, when I took this, I spent 15 years at a payer called Centene and joined it when it was a small company and left as chief growth officer when it was a pretty big company. But when you look at oral health and the construct of this overall industry, we're the only ancillary business that's billions of dollars. Only in healthcare would something that's billions of dollars impacting millions of people be considered ancillary and not something that you seek to drive integration. But we know the clinical outcomes that come. 50% of pregnant women experience some form of a chronic oral health disease during pregnancy. It drives higher incidence of preterm birth and preeclampsia, but many don't get referral to oral health during the time they're having their baby. 27 million people see a dentist every year, but they don't see an MD. 27 million individuals. And of course, we're in a country 1 in 5 people don't have access to dental insurance. And of the 80% that do, only 50% of them have an encounter each and every year in their dental benefit. So we're highly fragmented. in so many ways. The delivery channel, 80% of my business is done by independent practitioners. When you look at oral health as opposed to other parts of health. But the indicators on diabetes, on heart conditions, on what bad oral health means for outcomes is well known. So where we have seen the first influx of combining the data and beginning to find connectivity is not where you want it to be, having been in a payer. It's in the emergency department. 1.5 million oral health visits a year in the emergency department, $4 billion of expense. And I assure you, has anyone gotten oral health in an emergency room? I hope not. You don't want to, because the disconnect there is acute. But we are seeing some facilities that have consistent, because of the access and coverage challenges, have built integrated systems to connect their emergency departments to dental and oral health professionals. So we're seeing that continue to emerge, and we're partnering with Innovacer because this is really about data. How do we connect those 27 million visits to dentists to a primary care setting? How do we connect the host of people who go to primary care settings but don't see their dentist to ensure that we get better outcomes? There's no question about the connectivity, and frankly, it's a crisis approaching billions of dollars, hundreds of millions of hours of missed school and work for individuals. So it's exciting work to be engaged in, and one that is going to be levered by us talking, not just talking together, but working together to bridge the gap of information.
So let me follow up. I understand the connection to perhaps avoidable emergency room visits, and that's cost savings to the health system and to the ecosystem. Are you collaborating with any health systems like our neighbors here?
So I should say a little bit about CareQuest. Who, probably very few people in here know CareQuest before you walked into the room. So CareQuest dates back 60 years ago. We are the parent of Delta Dental of Massachusetts. Along the way, we created a leading Medicaid dental company called DentaQuest. And we sold DentaQuest, more people know what DentaQuest is, to Sun Life a few years ago. And we've dedicated the capital from that sale, and we thank Sun Life for that, and the work over many years to build that entity into focusing fully on changing the dynamic of oral health and the construct of overall health. So we are a startup, well capitalized, certainly with a great history, but beginning the work of integrating oral health in a medical dental integration pilot. And we are beginning that work with a number of partners. So this is a moving year. I'm a new CEO, having joined in September, but we are very open to having discussions around integration and being able to fund and fuel those efforts to bridge medical and dental integration. That's what we're here. It's a key pillar of success that we're seeking to achieve this year. So lots of opportunity if there are individuals that want to talk about doing work in the space.
Wade will be holding office hours over here afterwards if interested. Excellent. Excellent. Sounds like a great opportunity. Mark, let's talk about alignment. This is a challenge that we're seeing across AMGA health systems across the country, alignment and integration of physicians, and they're in different models. There's the employed model, there's the faculty model, there's the affiliated model through the CIN. How do you create shared accountability in all these different models beyond just the contract language?
I would love to say that we have mastered that. We are on a journey, and we are working to get that aligned. We're an academic health system, so like other academic health systems, we have an academic practice and we have a community practice. There's this natural tension that happens between those two practices. The academicians say we do the research, we create the protocols, and then the community practice says, well, we see the patients. So there's this kind of dichotomy going on there. So one of the things that we've done to try to bring folks together to help with things like contracting, to help with things like leadership, is to create a unified leadership structure. And then in that, so it's called Penn Medicine Medical Group, and in that PMMG, we have shared services, including contracting services, to allow us to be successful in both fee-for-service as well as value-based care. So we have shared services that would include things like quality, So believe it or not, quality in cardiology for our academic practice was different than quality in cardiology for the community practice. And for those of you who are not working with specialists a lot, quality is all over the place when it comes to specialty care. There is no real uniform definition of that. So interestingly, I'm on this committee for kind of bringing quality together at Penn. And every time the committee meets, we walk away with like, wow, that's really confusing. Like, how do we come up with like a single quality measure that is meaningful across ambulatory at Penn? So we're working to build that infrastructure, and part of that infrastructure, like I said, includes quality, includes population health, and we work with our managed care colleagues. And bringing these folks together actually helps us to be better contractors, because now we can go to our local Blue Cross is called Independence Blue Cross. We can go to Independence Blue Cross. We can go to Aetna. We can go to United and say, look, we're one health system. So yes, we're large. And as you mentioned, we have 500,000 covered lives in value-based arrangements. But we can come at it in a way to say that we have a unified way that we look at quality. We have a unified way that we look at total cost of care, and bringing that together has helped us to be better contractors. We got 2 new contracts, both from national payers that started on January 1, and we're looking forward to